if you do have specific questions about really specific health concerns, questions about if you specifically would qualify for medical assistance in dying, I encourage you to contact Alberta Health Services or to speak with your family physician. I've included the contact information for the MAID care team on the screen right now. And it can be as simple as calling 811 to get in touch with someone who can help you with that. If you haven't attended any of our events before, welcome. Dying with Dignity Canada is a national organization that really advocates for quality end-of-life choice and care. And we try to represent the 86% of Canadians who supported the Supreme Court of Canada's decision in the Carter decision, which led to medical assistance in dying in Canada. There are chapters across Canada, and we have some active chapters here in Alberta. So the Edmonton chapter has been active for maybe 7 or 8 years now, and we try to have meetings every 2 months. We did have a pause because of COVID, so this is actually our first meeting back since we paused in the spring. But we like to have speakers and updates and film viewings and personal support sessions and advanced care planning workshops. So I encourage you, if you don't receive emails from Dying with Dignity Canada, that you go to their website at the bottom of the screen and you sign up for their email notifications, and that's the best way that you'll find out about events in your area. You can also find us on Facebook. I'll just mention as well that there is some important stuff happening on the national stage right now, specifically with Bill C7. So these are proposed amendments to the medical assistance in dying legislation in Canada. 2 major proposed changes being the removal of natural death being reasonably foreseeable as a requirement for medical assistance in dying, as well as what we call Audrey's Amendment, which in some situations when you've been assessed and approved and picked a date for medical assistance in dying, that you can waive that final consent requirement. So we expect government to deal with this issue by December 18th. So obviously we're keeping a close eye on that, and our head office has been really active on this issue. If you want to learn more about Bill C7 and the proposed changes in that bill, I encourage you to check out the webinar that head office posted in September. And you can find that through this link on the screen, or it's really easy to find if you just go to dyingwithdignity.ca. So without further ado, I think we'll get into tonight's session. So our guest speaker tonight is Dr. Trevor Byers. He's a family physician with care of elderly training, working in Leduc, Alberta for the past 20 years. He has taken care of inpatients both in and out of palliative care and provides consultation services for geriatrics for the Leduc, Beaumont, Devon primary care network. In his work, he frequently deals with issues around cognitive decline and capacity. Dr. Byers has been an assessor and provider for medical assistance in dying for the past 3 years. Thanks so much for joining us.
Thanks for having me.
I think I'll stop sharing my screen so that we can go into a different view here. Okay. Okay, that should do it. So we're really pleased that you've joined us tonight because we haven't had any presentations at past meetings, specifically from MAID assessors or providers. And I'm really curious about your personal connection to the issue and when you first became aware of medical assistance in dying and how that has evolved for you over time.
Probably the first put a lot of thought into it. I didn't have any personal connection to it initially, but when I went into medical school, it was in 1993. in preparing for the medical school interviews, there was a very prominent case, that being Sue Rodriguez, who was trying to be able to use medical assistance in dying to end her life as she was suffering from ALS. Her case got turned down by the Supreme Court in 1993, but she did proceed with medical assistance in dying in 1994 when I was in first year medical school, with the help of MP Sven Robinson and an unnamed doctor who they could have been, but they never did end up getting charged.
I think for a lot of people, especially supporters of Dying with Dignity, Sue Rodriguez was a big influence on how they feel about medical assistance in dying and just general awareness. So I think that's probably the case for many of us on the call tonight. Do you feel that when you were going through med school that you received adequate training around issues surrounding death and dying? It sounds like maybe you specialized further in a field that maybe would have focused more on that.
Yeah, I can talk about, there's different levels of training. When you go into medical school, the first couple of years are mostly basic science and physiology. So you learn about what happens when the body dies and what brain death is, and that is more the molecular basis and physiologic happenings, but not about the human experience of death and dying and the social factors and the effect it has on people and their fears and family. That stuff doesn't come initially in medical school. Later on in clinical rotations, you start to see more of it. In medical school, we never had any specific rotations on palliative care, but we did in family medicine training. We did a 2-week stint in palliative care, and absolutely you would address death and dying and people's fears and symptom control and families' concerns, and those things would come up. Then on other rotations, internal medicine, surgery, you're always seeing sick patients, and it's always something that you're managing and dealing with. A lot of medicine is taught as kind of an apprenticeship, so you're with a preceptor and you learn from them. I was fortunate to have some excellent preceptors in palliative care and internal medicine, and who were very good at approaching the subject of death and dying. Sometimes you see healthcare workers and doctors who are just scared to discuss it and try to avoid it, but I had good trainers, so I did get a pretty good experience, I thought. And then as you're in practice, you're constantly trying to continue to learn. So as a family physician, I did palliative care, my extra training in care of the elderly, certainly dealing with chronic disease, symptom control, trying to improve people's function without being able to cure their illnesses, dealing with issues around losing capacity. These are things that I've dealt with all along. So learning for a doctor in death and dying is something that doesn't happen in a class once. It happens over years and with experience. So I felt that I had pretty good training, but that always has to continue as new things like medical assistance in dying come up. Then you have to learn the new processes, and every patient and patient's family that I've been involved with has taught me something different too. So you gain experience as you go.
And so when medical assistance in dying was first going through the courts in 2015, what were your feelings around that? Did you know right away that that was something you wanted to be involved in, or were you nervous to kind of be one of the first ones to get involved?
Yeah, I guess as a physician, my approach has always kind of been cautious. New medication comes out, it's kind of like, well, let's give it a little bit of time before we jump on switching everyone to the new one. With medical assistance in dying, anything that's new, it's a new set of processes to learn. It's the first people that are going to be ironing out any kinks that would be going on. I certainly was never opposed to the idea or opposed to the notion of medically assisted death. My idea was if I had a patient that wanted medically assisted death, that I would help them with that, but I would keep it to my patients. But as I was involved with a couple and got some comfort level with it and realized what a great service it was, I opened it up to be to provide for patients of other doctors or patients I hadn't met previously.
Did you ever feel stigmatized from colleagues about your choice to participate in this?
I've been lucky. I haven't at all. Doctors, we in the clinic where I worked at, I actually just left family medicine in the last month, and I'm now doing exclusively geriatrics, and I'm still providing medical assistance in dying. But in the clinic I worked at, we had 15 doctors, and there were varying degrees, backgrounds, different religious backgrounds, different personal beliefs. But as a group, we all recognize the differences in each other, and I think we're all very accepting of what each other bring to the table. In fact, the doctors that didn't want to participate in offering medical assistance in dying, I got the sense that they were relieved to have someone that they knew who would, so that they could refer them to someone that they trusted and knew who they were. So I've not felt any stigma at all. I do know of some healthcare workers that personally it goes against their beliefs, but everybody that I've worked with has always been professional, and they've stood back and stepped away if it was something that they didn't want to participate in. And even the palliative care team in Leduc, I know initially there was maybe some reluctance for some palliative care providers to be on board with this, but I never saw them delay referring patients for medically assisted death if that's what the patient wanted. So I've really felt that it's been embraced, and I haven't felt any stigma at all.
That's great to hear. Do you have any sense of if there are an adequate number of assessors and providers in the province, or are you, as an assessor and provider, do you feel overwhelmed?
I get asked probably about two a month, two patients a month. So for me, that's reasonably doable. This is something that most providers fit in outside their normal work schedule. So a lot of the assessments and provisions are done in the evenings or on the weekends, or I'll run out during my lunch break to meet with a family and a patient. I don't feel overwhelmed. I talked to Jo Hagerud from the MAID office, and she says currently there are enough assessors and providers to meet the demand, and I see it kind of being taken up by my colleagues. More of them kind of doing it usually as patients of theirs request it, and then if there's other people in the clinic who are familiar with the process, then they get more people involved. So it seems like there are enough people, and there's certainly possibility for more to become involved as if demand goes up.
Would it be fair to say that the actual provision of medical assistance in dying is relatively straightforward? Is the harder part the assessment process?
Yeah, the process is the hard part. The actual procedure is almost identical as if you were going to put someone on a ventilator. So anybody that's done an anesthesia rotation or spent any time in surgery or worked in an emergency department where they've had to intubate someone, they know the order of the medications that they're given. In medical assistance in death, it's far higher doses, but it's the same basic idea. So that part's not unfamiliar with us, and that part only takes a few minutes. It's the hard part is the research into the patient's background, looking at their family situation, making sure that they've understand all their treatment options, and making sure that those have been offered to them. Being comfortable doing a capacity assessment. As a geriatrician, I do capacity assessments all the time, dealing with Alzheimer's disease, Lewy body dementia, frontotemporal dementia. We're enacting personal directives, powers of attorney, trying to assess whether people should be driving. So for me, that's something I do every day anyway. So it's not something too formidable in my mind, but the assessment, the paperwork, there's probably about 20 pages of paperwork to fill out, which is all in. The questions are kind of confusing. They seem like they're written by lawyers, and it's a bit of a daunting process to go through, especially the first time as a physician. The first time you kind of muddle through it, and you get more familiar, more comfortable with it as time goes on, and you do more cases.
Could you give us just a broad overview of what the process is if you receive a request from a patient?
Sure. So when patients ask me initially, if they're just asking me out of the blue about medically assisted death, I always refer them to the MAID office to get the process started there. So they put in a request for medically assisted death with the MAID office. Then the MAID office would contact me as the provider to do an assessment. They would also have to get a second physician to do an assessment. It doesn't matter what order those are done in. So when I get a referral, I'll spend time looking at the patient's chart on Netcare, determining what illnesses they have, what qualifies them for a medically assisted death, what treatments they've had, whether they've had palliative care, who's been involved. I get all that information down, and then I'll make a appointment to go talk to the patient and their family if they want the family there. I'll explain what the process is, how the medications are given, in what order. I'll ask them a series of questions to make sure that they're eligible and they know what they're signing up for. In order to be eligible, they need to have healthcare in Alberta. They need to not be pressured into medically assisted death. They need to understand what all the options for the treatment of their condition were. They don't have to necessarily have had all those treatments, but they have to have known what's available and have their reasons for whether they want to pursue them or not. And then there's a series of questions on which symptoms are causing what degree of suffering. And once they're eligible, so I'll sign off on that assessment. And then once the second physician does the same thing, then with the MAID team, a date gets picked on when the patient wants that provision, and we try and accommodate whenever works best for them. If they want family around there, then if it's on a weekend, then we try and make sure that happens. If they want it done at home, then we try and make sure that happens. If they want it done in the hospital, we've done that. That's a lot more difficult these days with coronavirus pandemic. So almost all of the ones I've seen have been at home since the pandemic began. When we have a date, then I have to go through and order the medications. This is easy to do when it's done in the hospital, because the hospital pharmacy will do up all the medications for you and provide them in syringes. On home assessments, I have to get them from a community pharmacy. So we have a couple in Leduc that will offer them, not all will. So I have one that I work with in town, and I send in all the prescriptions and fill out the special authorization forms. When the medications are ready, I'll pick them up. Then I have to draw them up into syringes before the MAID procedure. On the day that it happens, myself and a nurse sent from the MAID office will go in and again discuss the process and the procedure and offer the patient to withdraw their consent if they want to change their mind at any time. They certainly are able to. When they're ready, we give a series of medications that initially relaxation, then pain control, then a medication that induces a coma, and then finally a paralyzing agent that will cause the patient's death. After that, the family contacts the funeral home. They'll come up and pick up the patient's body and take it to the funeral home when the family is said their goodbyes. Then I have some paperwork to fill out, and I contact the medical examiner to let them know that this happened and what the illnesses were, and the medical examiner completes the death certificate and sends it to the funeral home. And that's kind of start to finish what happens with medically assisted death.
So, I mean, that sounds like a lot of work for an assessor or provider. In the beginning, there were some questions about whether physicians or nurse practitioners were being adequately your work on this. Do you feel that you are, or that assessors and providers are compensated appropriately for that, or is that a barrier to people getting involved with this?
Good. I think it's something they did right. It's time-based, so it's not a set amount for the procedure. It's a per 15-minute code. So if something's more complicated, you have to spend more time. Patients or family members then you get compensated for the time spent. It's one of the few things in medicine as a doctor where I actually get paid for time spent reading the patient's chart, time spent filling out paperwork, time spent phoning pharmacies. Most of that stuff is not covered by doctor fees, but in medically assisted death it is. The only thing that they don't compensate us for is the time spent in travel. So if I have a patient that lives in, then for the assessment and for the provision, that's a couple hours. That's not compensated. But otherwise, the time is compensated, and it's similar to what I would make working in the clinic. So to me, it's not a barrier, and I haven't heard it as being a barrier to other physicians. I think the thing that's probably the biggest barrier is just how daunting the paperwork is, and the process, and people being scared that they're not comfortable doing capacity assessments or being able to determine if someone is eligible for medically assisted death. That's probably the bigger barrier, is just the kind of unknown and not having gone through the process. And it is a daunting process, a lot of paperwork.
Someone's asked if you know what it actually says on the death certificate if you've died via medical assistance.
That's a good question. I don't know what the medical examiner fills out on there, because it's not us that completes the death certificate. So I haven't. Oh, sorry.
Assistance in dying, and then it lists reasons like the conditions underlying. Okay,
I've got a specialist pharmacist here who's actually my wife, who is a hospital pharmacist at Leduc Hospital, and she says that the death certificate will say medically assisted death, and then list the underlying medical reasons as to why the person was eligible for MAID.
Great, thanks. I see a few questions coming in through the Q&A, so we'll keep monitoring it, and if they're relevant to our discussion at the time, we'll definitely ask them. Otherwise, we'll keep some time at the end as well to address as many questions as we can. I know a question that I've got a lot, and I have myself, is how do you view, or do you view, a distinction between palliative care and medical assistance in dying? And why do you think there's been a pushback from some in the palliative care community to including medical assistance in dying as an end-of-life option?
Yeah, it's funny to me. I mean, I'm a practically minded family doctor, so we kind of deal with everything. And to me, to see medically assisted death as separate from palliative care is odd. Palliative care to me means symptom control without fixing the underlying condition, and medically assisted death firmly fits in with that. I think there are things in palliative care that are done when people are near the end of their life that probably hasten people's death, but provide symptom relief that are not, in my mind, terribly far away from medically assisted death. When I was doing my palliative care rotation at the Grey Nuns, we had patients with fairly horrific head and neck cancers who are at risk at any time of obstructing their airway or hemorrhaging badly, and they all had orders on their chart for, if they needed a really high dose of a sedative, if that happened, that it could be given. If patients' symptoms were out of control and they were very near the end of life, we would put them on IV drips of dilaudid, strong opioid sedatives like midazolam, which generally will keep people very sedated and asleep, and it is going to lead to a quicker death, but it's a palliative care maneuver that's frequently used. To me, medical assistance in dying isn't a great leap from that. So, as a doctor who's provided palliative care and medically assisted death, I think, to me, they're in the same category. I can't really speak to why some people believe they're separate. I suspect it probably has to do with underlying religious beliefs, but I can't say for sure. To me, they're in the same category.
That's a refreshing answer. And I think something that maybe gets lost in discussion around medical assistance in dying is is there an impact on the assessors and providers? And do you feel that you have supports in your profession to help you through, as you said, sometimes 2 a month?
Yeah, and as a doctor, I mean, I've done emergency medicine and nursing home care and inpatient medicine, palliative care, medical assistance in dying, and there are, you know, emotionally traumatic things that we see in all different fields. I mean, some of the most troubling things I've seen have had nothing to do with end of life issues. I mean, I was working in emergency once when a 9-year-old girl came in the middle of the night and was told by her parents to walk to emergency to have her medical problem addressed because they were too busy drinking and they couldn't be bothered to bring her in. To me, that emotionally is a lot harder to deal with than helping someone with their symptoms at the time of. So I don't haven't personally had anything but positive experiences with medical assistance in dying so far. Every case I've been involved with, families are grateful. The patient, you know, after having months, years of suffering leading up to it, I had patients that were always tearful and frightened and anxious, finally at peace and comfortable and even joking. I mean, there's dark humor when people are getting medically assisted death, and as a physician, we certainly appreciate that because there's plenty of that in our training as a coping mechanism. But I haven't felt personally that for being a provider in medical assistance in dying has been something that's been bad for me emotionally where I've needed support. But that is available to us. We had one case that didn't go as well as it could have. It was a patient that had poor IV access, and while we were administering the drugs for the medically assisted death, the IV blew. So we had to pause for half an hour before we could establish another line, and that was a bit distressing for the family. The patient had actually received a fairly good sedative, so he snored through it, but it was difficult. And after the case was done the next day, we the nurse and I that were involved, the administrators reached out to us and thanked us and asked us if we needed any help, and so we feel like we're supported there. For doctors, we have a support program called the Physician and Family Support Program that's run by the AMA, and if we have any issues with where we need psychological supports or counseling, we're always free to utilize that service as well.
I think you're probably aware that the Dying with Dignity chapters have been involved with volunteering to witness people's record of request forms. And I can't speak for everyone, but in my experience, the people we meet with are often very determined that this is the right choice for them. I've never had anyone seem wishy-washy about if this was right for them. Is that kind of your experience as well?
Yeah, I haven't seen anybody where there was any waffling at all. It's usually the people are very, they know exactly what they want. They're grateful to have the choice, and they're happy you're there to provide it. It's you know, it's like I said, it's been an overwhelmingly positive experience. I haven't had any encounters that have made me think otherwise to date. That being said, it's not something that if someone doesn't want that, I'm not going to try and bring it up or convince them that that's the way to go. Everyone has to choose what's right for themselves. And, you know, if medical assistance dying is what they want, then I think they should have that option.
Yeah, and I think for me, it's really shown that this is not a decision that they've come to lightly and that they've considered over time. So I'm glad to hear that that's your experience as well.
Yeah, I have been involved in cases where the patient is absolutely certain, and they may have 5 or 10 family members in the room at the time, and there may be 1 or 2 family members that are, you know, they're not sure. And I have, after the procedure, has been done. I have kind of overheard quietly being said, well, that's the right way to do that. So I've heard people kind of make up their mind after witnessing it. So you kind of see people change their position when they're involved, and I think familiarity is something that takes society a while sometimes to realize that what they think is going to be a problem isn't, and it takes a while to get used to change.
Carl, did you want to add something?
Yes, I was going to refer one of the questions from one of our participants today. Dr. Byers, what's your opinion of the proposed 3-month assessment time that's being required in the Bill C7 proposed new legislation?
Yeah, so the Bill C7 is now breaking medically assisted death into 2 streams. So there's the stream that what we have now where people's death is a reasonably foreseeable event, have a 10-day period of time where they ask for a medically assisted death before it can be provided. So a 10-day reflection period, which can be waived if people are deteriorating and they may imminently lose capacity. What's being proposed is that for people who don't have a reasonably foreseeable death, could be living for years, decades longer, their waiting period would be 3 months instead of the 10 days. What I can say is I'm glad I'm not making decisions like that. It's difficult to make decisions that everyone's going to be happy with. I can tell you as a doctor, the primary rule in medicine is to first do no harm. So you want to make sure that when you're doing anything that you're not going to bring people to harm by what you're doing. So when these new issues are introduced like this, I think you're always going to err on the side of caution in making sure that you're doing the right thing for people, and you're not going to end up providing MAID for someone who may have changed their mind after a period of time. So I can understand the 3-month reflection period there. Again, it's tough, arbitrary timeframes to make. I also I like the idea that they want to have a doctor in the area of specialty that's dealing with the person's problem to have to weigh in on it. So as a family doctor, if someone's asking for medically assisted death for for a problem that's not in my area, if it was a neurologic condition, it'd be nice to have a neurologist opinion on, whether all treatment options have been exhausted for that person. So that 3 months would also give you time to allow those to happen. That 3 months can also be waived, I think, from what I read, if a person may be losing capacity in that time frame as well. So not necessarily written in stone. But I certainly understand where the longer time frame comes from.
Mm-hmm.
There's a comment here that just says, thank you for your clear ideas and convictions. I believe your patients benefit from your care and support.
Oh, thank you.
And there's another question around process. Someone is wondering if self-administration is an option in Canada.
It is, as of now, I don't know if anyone has chosen that in Alberta. There are 2 medical protocols. There's the intravenous protocol, and there's a oral protocol where a person can administer themselves. Nobody that I've been involved with has chosen the oral protocol yet, so I have no experience with it.
There's another question here. There's great questions coming in, so we might as well start addressing some of them. Someone has asked which number they should contact if they're interested, and I'll just mention again, it's as simple as contacting 811, and they can direct you to the Alberta MAID care team. Someone else is wondering if you've encountered a request from someone in a facility that doesn't allow the provision of MAID, and if so, how have you dealt with that?
I haven't. From what I understand, Covenant facilities don't allow MAID on their premises. They'll allow the assessments and paperwork to be completed, but then they have to move the patient off their premises to provide MAID. I don't work in Covenant, so the Leduc Hospital, where I have privileges, allows MAID to happen within the facility, and all the other ones I've done have been in patients' homes.
Have you ever had to provide MAID to someone earlier than what they ideally wanted because they were afraid of losing capacity to consent?
I haven't. In fact, we run into the opposite problem more often. We're often getting asked to provide MAID immediately. So the person is in the hospital, very ill, develops an acute medical problem on top of their, cancer or whatever other problem that they might have, and then wants MAID today. And that is a challenge given the 2-doctor process, kind of trying to get the medications lined up, getting all the paperwork done. I've seen more people that have almost waited too long than people who have gone for it earlier because they're worried about losing capacity. But in those cases, we still do try to scramble as fast as we can. There was only one, I think, that he just gotten sick too quickly, and the day he was supposed to have MAID, he ended up, he died that day anyway, just not of MAID, just from the acute medical problem.
Speaking of capacity, we did receive a couple questions ahead of tonight's webinar, and we've received one as well in the chat. It's essentially asking about the ability of a personal directive or advanced care plan to request or enact MAID. Can you explore that topic a little bit? I won't get into the details here of people's individual circumstances, but I think in general, they're wondering, right, when do you think that will be available, if ever?
Yeah, that's something that I don't believe is being addressed in this new round. Right now, you have to be able to consent, or have the capacity to consent to MAID both at the time you ask for it and at the time it's provided. When that would change to include illnesses like Alzheimer's disease or other types of dementia where people are going to lose capacity, I'm not sure. As a provider, we follow the rules that we have. I can definitely see a role for it in cases of dementia where, if it's well established, if there's a clear decision maker appointed, a family member or someone that's trusted, and it's spelled out specifically that they would want MAID and in what scenario, then I can understand that being something that would be allowed down the road. I don't know when lawmakers are going to pursue that.
Would it be fair to say that in some cases, broadly speaking, mild forms of Alzheimer's or early forms of Alzheimer's, that an individual might qualify if they still had capacity?
Well, sure. Yeah. Alzheimer's doesn't immediately mean you're not capable. In order to be capable, you have to know what your problem is, you have to know what your options are, and you have to be able to explain why you want to choose the route you want to choose. And whether you have your short-term memory or can drive a car successfully or add numbers together doesn't have any impact on whether you're capable to make a decision. So as an assessor of capacity, I would just ask the person, what are your issues? What are you asking me to do for you? Why do you want to choose this route? And if they're very clear and they understand what's going on and they understand what they're choosing, then they're capable, regardless of what their diagnosis is.
And I'll just clarify for folks on the call that in Bill C7, they are looking at Audrey's amendment. And I mentioned this at the beginning, but this feels like a step towards in advance, in the sense that in this case, if you've been assessed and approved for medically assisted death and you have a date for that medically assisted death already chosen, if between that time you were to lose capacity, then in those cases, the requirement for final consent could be waived. So that is maybe a much narrower group of people than what I think the questions in tonight's webinar are addressing, but it does feel like perhaps a small step towards that.
Yeah, and I think small steps get you to your end goal. A small step's better than no step, and I can certainly, as a geriatrician, as a family physician, I've had patients that I know would have fallen in that category. So yeah, I can see it. I think you're dealing with trying to set black and white rules on gray areas of health, and you're always going to have to arbitrarily set the needle somewhere. The only way to make sure you're completely respecting everyone's autonomy is to allow a medically assisted death, no questions asked. And the only way to make sure you're not ever providing MAID to someone that where it might be inappropriate would be to not do it at all. Somewhere you got to set the rule or set the needle in the middle of that somewhere, and it is always going to be cases where it's hard to decide one way or the other. But I think I'm glad that this is available to people, and I'm glad that they're looking at expanding it now that they've had some experience with it, and I hopefully will continue to look at it to expand it further as we get more experience.
So I'm just conscious that we're about 45 minutes in, so maybe we'll just try to answer a bunch of the questions in the Q&A and the chat for you. So Carl and I can throw some of those out to you. There's a question here about if any of your MAID patients have donated organs.
I haven't had any done that. I did read about, I believe it was a physician that was the first to donate organs when she had medically assisted death. If that request came up, I would have to talk to the MAID team or organ donation groups to find out how that would proceed here. Haven't had that come up yet.
Okay. There's also a question about hospices as a tool for end-of-life care. It looks like this person's wondering if you know if there's differences in hospice organizations, maybe if they allow for MAID on site. I think that might be what they're asking.
I think every hospice would be different. It would depend on whether they fall under the umbrella of covenant care or or capital care might be different. It would depend on the administration of that facility, whether they would allow it or not. All the facilities that I've had privileges in would allow it. So it's not an issue that's ever come up with for me in Leduc.
And just a reminder to folks, it's easier to track your questions in the Q&A box instead of the chats. So if you want to throw them in the Q&A, that's helpful for me and Carl trying to track them all. Carl, do you have one you want to ask there?
No, not right now. No.
Okay. Someone here is wondering if you've ever had to deny a request.
No, everyone I've been referred has been appropriate for MAID.
And given that we're obviously dealing with the pandemic right now, has this been available for COVID patients?
So far, I haven't seen anybody that's actively had COVID requesting MAID. I don't think the diagnosis that a person has would preclude them from being assessed for MAID. So if someone had COVID and they've met the criteria otherwise, then I certainly would look at being a provider for that person. You'd have to obviously wear the right protective equipment, but I wouldn't deny someone because they had COVID.
There's another question here relating to how are we going to alleviate the fears from people in the disability community that they might be forced into MAID?
Probably just with time and experience. I think that's the way you alleviate fears in general. I've seen nothing from what I've done that would suggest that we're pushing people to this decision. This has to come from the person themselves. This is not, I'll ask patients, I'll ask families to step away so I can talk to people and make sure they're not being pushed towards a decision. That's clearly part of the rules. But yeah, as far as how you can help someone's fears, I think is just with time and experience, and hopefully with familiarity, it becomes less fearful.
and probably always doing that vulnerability assessment on an individual basis instead of assuming that an entire group of people are quote unquote vulnerable.
Right. Oh yeah, everything is individual. I mean, there's no, that's part of the problem with you're trying to make blanket rules for people when no two people are the same. That's why it makes it so difficult. It's almost, you know, I see a letter about a personal directive on here. When I tell people, when I'm instructing them to do personal directives, a personal directive, for those who don't know, is a document that you fill out where you can either spell out what you would want if you become incapable as far as your healthcare and housing decisions go, or you can appoint someone to make those decisions for you. I always encourage people to appoint someone that they trust to make those decisions for them, because it's nearly impossible to spell out what you think is going to happen to you in the future. I've had patients where they've written out lengthy scenarios, and what happens to them at the end of their life almost never matches what they've written out, and then it becomes useless to try to apply that document to the person. So you want to try and use someone that knows them well to help, you know knows their values, knows what they would want to help make that decision. And I think the same goes for when you're trying to assess people for medically assisted death. Everybody's different. Everybody defines suffering differently. You know, there was one case about a patient who chose MAID because she didn't want to go through another lockdown in her facility, COVID. You know, whereas other patients might never want to leave their room and talk to another person because they prefer to be by themselves. So, you know, what's one person's suffering is another person's utopia. It's you have to, you know, you have to look at people individually and assess them each on their own merits.
Two questions just came in, which has been receiving a lot of attention in the media lately around mental illness. What are your thoughts around provision of MAID and mental illness?
Yeah, that's a tough one. I mean, I've you know, as a family doctor, I have patients who have attempted suicide and failed and are now living a happy life with meaning. So, you know, when you see cases like that, it makes you worried that, you know, you could do harm if you provided MAID for someone who might, you know, have a treatable illness. I think in that case, you would want to make sure that the person is assessed by someone in that field to have exhausted treatment options and to not be, you know, to make sure that you're not doing something that would be premature, that they couldn't be properly treated otherwise for. I have a psychiatrist friend who I sent a text to before this to see if he had any input for me, and he basically said that's a tough one. So he also said that he would want to make sure that the person didn't have something that was treatable.
Brad, there's a question here of must patients in covenant care leave the facility for MAID even when there's a willing physician there?
Yeah, so as far as we know, covenant facilities still are not allowing MAID on their premise. And our organization has referred to this as a forced transfer. When an individual would like to receive MAID in that facility, maybe that's what they consider their home because they've been in there for a while, or they don't have anywhere else to go, then they are transferred out of those facilities to receive MAID. I know in one case we did have a patient who we were witnessing their record of request form tell us that they were worried about where they were going to go, and they were talking about maybe needing to get a hotel room to receive medical aid in dying. And so we have seen that this is quite distressing to patients in those circumstances. Some good questions still coming in. Has anyone ever changed their mind at the last moment?
Not that I've dealt with to date.
Are there any roles for family members to assist in MAID?
I think being supportive for the person that's facing this decision. It's not an easy decision to make, and I think, being there for them and supportive of what they want is what family members need to do. Helping them contact the MAID office, I guess, if they need help doing that, is another thing that family members can get involved with. And just to be accepting of this decision. I mean, sometimes I've seen where patients have struggled with the decision, even though they clearly that's what they want for themselves. They're concerned about upsetting their family. So family members can, if they want to help that person, is to, respect their autonomy and their decision making and tell them it's their choice to make and support them in that.
I've heard a couple anecdotes from even friends who've experienced MAID deaths with family members about the dying process and the grieving process are a little bit different. In one case, a friend was able to, say, listen to their loved one's heartbeat as they received MAID. Can you comment on how that might change the dying and grieving process from how it traditionally was happening?
Yeah, I think traditionally people would slowly deteriorate, and then they would spend the last hours to days unconscious, and family members would, take shifts at bedside and waiting until the person finally passes away. The MAID process is a far more interactive one. The patients generally still, has to be by the rules right now. It's conversive and capable. So there's back and forth talking, saying of goodbyes. I've had, playing of the favorite music. I had a patient where they gave some of favorite fish hooks to put in his pocket, or mementos that, to take with him. So it's definitely a different feel. I had one patient that was an artist and had a number of paintings brought in. So the bedside was surrounded by art that she had created, which was a beautiful touch. And it's not something I've seen happen in other palliative care settings, though that could happen. But it's certainly kind of more of a set stage, and it's more interactive, and it's a different feel. To me, it's for the people that choose it. I think they're grateful for the they know what the time it's going to be. They know it's not going to drag out. They know they can have their final goodbyes and be there at the end, and they can all be there rather than one or two of them taking shifts. So for those people, it's great for them. But again, it's a personal choice.
Some good questions coming in here. Someone's wondering if there's any resources for a patient who has family members who are at odds with each other. Do you know of any resources that would be useful for people in that situation?
I don't know if there's any specifically to help through the MAID process. The MAID team would be better for asking that question. Certainly would be something I would ask if anyone was considering it or asking for MAID, if they had family members that were not happy with that decision, to see if there were specific resources to help with that. Other than that, mental health counselors are often well versed in dealing with family disagreements and dynamics, and I imagine this would be something that they would look at as well.
I know in a lot of the facilities we've been involved in, social workers have been a big part of the process, and I wonder if they would be a useful resource.
Yeah, for sure. And it slipped my mind. I haven't done an in-hospital one for quite a while. So, but yeah, absolutely. The social workers are excellent at dealing with families and working with family dynamics. So they're a great resource.
Can you see a role for end-of-life doulas being able to support families and or medical institutions with the MAID process?
Sure. I haven't seen, I haven't had a patient that had an end-of-life doula, but it's their experience, and for sure, if that's what they feel would you know, comfort them and help with their family. And sure, I'd certainly welcome that.
Someone has asked where nurse practitioners stand with MAID.
I can talk to the ones that help with it. Most of them, like I said, this isn't any of our full-time job. We're, you know, the nurses I've provided MAID with are emergency nurses, cross-cancer care nurses, intensive care nurses, and generally the ones that I've talked to have said, you know, they've seen people coming through intensive care and emergency and the cross with unrealistic end-of-life expectations, and this is something that, you know, they feel strongly about, and they want to help provide MAID. So those are the ones that I've been working with so far, but they're certainly on board with it.
Here's a fun question. Someone's wondering if you see any usefulness of psilocybin treatments in end of life in the future.
My pharmacist wife's a big fan, so maybe not personal use, but exploring new treatment options for pain and suffering, for mental health issues. I'm all for exploring anything that will help people with their illnesses or symptoms. So yeah, for sure, it's an exciting field to be able to look into. As a doctor, I'm a scientist, so you want to make sure that there are proper trials done that show their benefits. But yeah, absolutely.
Someone here just commented that they take a lot of comfort in your comments, so that's great. There was a question here as well, if Dying with Dignity has any resources on what should be included in a personal directive. And at dyingwithdignity.ca, there are lots of resources around advanced care planning, and the Calgary chapter of Dying with Dignity has been really active, and they've hosted webinars and sessions on advanced care planning. And in the Edmonton chapter, Carl and Baz have been active on that front as well. So I encourage you to check out dyingwithdignity.ca as maybe your first stop, and then getting in touch with the local chapter. Carl, do you want to add to that?
Yeah, if I could just add there, I think with a personal directive, what's really most important is what your personal values are, of really expressing your personal values, which is going to be different for each person. So it's really hard to have a set kind of thing. And it's very important that it be something that truly represents you as a person and what your values are.
I'm just conscious that it's now been an hour, so maybe we'll just take a couple final questions here and then wrap up. There was one question about if you've ever had a disagreement with another physician, maybe in your assessments.
Around medical assisted death, no, I have not. Have I ever had a disagreement with another physician? Yeah, yes. I can tell you a story about a disagreement I had with a physician that's not MAID related, but it's kind of funny. I had a patient with a very slow heart rate in emergency whose heart rate was down in the low 30s, who I thought needed a pacemaker, and I called the city to try to arrange that. And the cardiologist I talked to was rude, told me to send the patient home and make a referral to his office. So I yelled at him to say I wouldn't be referring to his office, and I hung up the phone forcefully. And then about 6 months later, my dad had a heart attack. And when I called the hospital to tell them what my cell phone number was as I was coming in, they said, "Oh yeah, Dr. So-and-so is with your dad right now." I'm like, "Oh really?" And it was that doctor. So I thought, well, maybe he won't remember me. You know, he usually gets hung up on a lot, and he certainly did remember me. So my dad's okay. Yeah, he did a good job. So,
oh, good.
And that guy's always been nice to me since. So yeah, no, doctors, we're pretty good about having our differences and having disagreements, and not really, like, I think for the most part, not taking it personally. Like I know my colleagues treat some things different than I would, and we don't always agree on diagnoses or what's proper, but in general, we're pretty functional and work together. I'm sure that the 82 participants have met doctors that are otherwise, but most of the ones I work with are generally accepting of differences and disagreements, and If there was something that we disagreed on in a patient assessment, we'd probably get a third opinion. That would be my approach, or talk it out and find out what we disagree on and try and come to some sort of a common ground.
Our friend Carrie from the Calgary chapter just mentioned that there was an ACP Goals of Care presentation by the Calgary chapter on October 23rd, and that is available on Dying with Dignity Canada's website for anyone who's interested, but also the people who asked that specific question. Someone else was wondering if there's a Central Alberta chapter. I think the only really active chapters right now in Alberta are Edmonton and Calgary. And Calgary has been phenomenal and hosting lots of sessions and have been really great experts in advanced care planning. So if you're joining us from Southern Alberta, I encourage you to get in touch with them. And if you want to start a new chapter in Alberta, I'm sure head office would be thrilled about that. So you can reach out and find out about how to do that.
Maybe I'll say one thing about personal directives, seeing as put on my geriatric hat right now. If you do find yourself filling out a personal directive, I think the most important thing to do is to appoint someone who you believe knows your values to make decisions for you. You can appoint a hierarchy of people, so you can say this person, and if not this person, then this person. I would certainly do it that way, as opposed to saying these three people are going to make my decisions jointly, because three people don't always get along and they don't always agree. So appoint one and then appoint another one after that person. That's a lot better than trying to spell out what your beliefs are. Is just to get someone that can look at the situation that you're in and make that decision for you if you can't. The second thing is when you fill out a personal directive, you have a choice of determining who determines your capacity. So it can either be the agent you appointed and a doctor, or it has to be two doctors. If you trust the agent you appointed to make your decisions, I would recommend choosing that option, so that the agent is the one to determine your capacity, because then they only have to find an opinion from one other doctor. Otherwise, they have to find two doctors that are willing to do a capacity assessment, and it's hard enough to find one. So just if you do a personal directive, those are two things that I would recommend. Pick someone to make your decisions that you trust and that knows your values. And the second one is, when it asks you who determines your capacity, choose the option your agent plus a doctor, as opposed to two doctors, just to make it simpler.
Mhm.
And I think we've learned from, especially the Dying with Dignity Advanced Care Plan toolkits, that there are questions in there that you can do with someone else to determine if that person knows your values very well. And I've heard from other people that maybe your husband or wife aren't always the best person to choose as your secondary decision maker. So it is a big decision, an important decision, and there are tools out there to help you make that decision. June from Calgary just mentioned that there are interest groups in Sundre and Didsbury called Death Matters, dealing with end-of-life issues. So that may be somewhere you can look to if you're not from Edmonton or Calgary to get involved a bit more. Maybe we'll just end with this question. Do you ever think MAID would be allowed for an older person who simply would like to end their life, maybe just a condition of frailty, for example?
I don't know. I mean, that's from the way I read the legislation, I think that's probably a long way off for society to contemplate that. That's probably one where it would be a court challenge, that kind of like what this has been forced with a court challenge. I suspect a lot of the broadening of the medical assistance in dying for things like that will be someone in that position that challenges, you know, their charter rights, and then a court decides that that's something that's going to, have to be included, and then legislators will have to come up with that. I don't think society is ready for that right now.
I think we'll wrap it up, as we are past 8 now. I know there are still questions remaining. I encourage you to reach out if you still need to get those questions answered, and hopefully we can help you with that. Carl, do you have any final comments you want to add?
No, I think this has really been very helpful. Really appreciate your being with us, Dr. Byers. It's really great.
It's been my pleasure.